first thing I'm going to do is just put the local anaesthetic in.
The strand needles are in theatre on their tray, numbered and ready to be inserted.
It's going to be big C.
Using the ultrasound markers, the operator can then start inserting the anterior needles.
So at this stage we're not inserting the seeds, we're just inserting the needles into the correct transverse plane, the correct XY plane. I've placed the ultrasound so it's in the middle of the prostate gland, and that allows me to ensure that the needles are lying around the periphery of the prostate. The first needle I insert, I'm obviously looking at a coordinate to get an approximate indication as to where it's to go. And then the subsequent needles are very much in relation to that first scout needle, either 2 up, 1 across, or 1 down, 1 outside. And it's more intuitive, and one's implanting the needles where the prostate is, as opposed to just sticking rigidly to a grid or a coordinate, which is sometimes where the prostate isn't.
A key aspect of the 4D brachytherapy approach is that it allows both operators to maximise their theatre time. Tasks that were traditionally carried out one after the other can now be performed simultaneously.
Whilst the operator who's putting the needles or the radioactive sources into the patient, there are jobs that the operator who's using the planning computer can be getting on and doing. It gives me an opportunity just to outline the urethra and the rectum on each of these slices, which of course is important because we need to know what dose these structures get at the time of the real-time part of the planning procedure.
Undoubtedly, the procedure requires 2 trained people to perform this. So whilst I may be inserting the seeds, my colleague who would be driving the dose planning computer would be already undertaking the real-time planning to optimise the next part of the procedure.
The position of the loose seeds can start to be optimised, and this means when we get to the end of the stage of the strands being inserted, the plan is more or less already done.
To maintain accurate dose predictions, the actual XY position of each implanted needle is verified. The stranded seeds are now ready to be inserted.
I'm just going to line up the base of the prostate with the base plane as outlined on the ultrasound, and then Robert's going to bring the virtual image of the prostate so they all lie in sync. Okay, and that looks fine. With each new needle, I'm just going to rotate the bevel of the needle, rotate the needle so that Robert can clearly focus on that needle, and we know that this is the needle in question. I'm going to advance it now to the base of the gland, right up towards the bladder. I'm going to move the little markers forward. The seeds are now sitting at the tip of the needle. I hold the plunger still and withdraw the outer sheath, and the seeds are again implanted. And the nomogram is going to allow that length is exactly right.
The stranded seeds allow us to push the radiation dose out just a little bit further, particularly at the base and the apex of the prostate, without fear of the seeds migrating in the veins and moving to the lungs.
As well as generating a wide dose coverage, the 4D brachytherapy technique avoids issues with mobile prostate glands.
There is a considerable amount of motion of the prostate during an implant, some prostates by more than others, and that's why we feel it's very important to insert the seeds in the longitudinal view rather than some techniques where one was relying on the transverse image. It's very difficult to determine whether the needle is actually passing through the prostate or just pushing the prostate unless you're actually looking in that longitudinal view.
In contrast to techniques that deliver stranded seeds based on the retraction planes, 4D brachytherapy uses a different approach.
We've found that there can be a tendency to focus on these retraction planes rather than actually where the prostate is. So in 4D brachytherapy, we insert the needles to the base of the prostate as far up as we can, irrespective of whether that's the 5mm retraction plane, the 7mm or 7.5mm. And by doing that, we can really conform the implant to the shape of the patient's prostate rather than just relying on what can sometimes appear a rather complicated game of battleships to do the procedure.
This clear visual target, the base of the prostate for every strand, means the implant is both quicker and much more flexible to any minor variations in the size of the prostate gland. The 4D implant is not just about what's going on inside the prostate, however. The technique has evolved in such a way that the operators work together when implanting the seeds.
When it comes to actually implanting the radiation, it's very important that both operators come together. We've devised the technique that works well for us, is that the person that is registering the seeds on the planning computer holds on to the cradle of the ultrasound and thus dictates the speed of the procedure. So we won't move on to the next needle, or can't move on to the next needle, until those radioactive sources have been registered onto the planning computer. And I'm swinging the cradle backwards and forwards and picking up the needle, and as it were, tuning the ultrasound into that needle, and at the same time making sure that the computer is correctly identifying the right seed chain and marking it as implanted.
The procedure goes along at an orderly pace and we don't get out of sync ourselves.
Just occasionally, if you don't do it in this team-like way, then it can get out of hand. One's working quicker than the other and suddenly everything's disjointed.
Working as a team like this is crucial to the success at Guildford and comes from a belief that both operators' roles are interchangeable.
We have always decided that it was best that we would both be able to undertake all different parts of the procedure and be trained in different parts. So in some cases I'll put the seeds and he will drive the planning computer, and in the next case we will reverse those roles.
By working this way, each person's skill and understanding of the procedure develops, the team is more flexible, and the quality of the implants improved. With the anterior and lateral strands now implanted, the action is repeated for the last 4 posterior strands. Inserting these posterior needles can push the prostate anteriorly. It's good practice at this stage to realign the prostate in the transverse and longitudinal planes. Their close proximity to the rectum and the chance they block the view of other strands in the ultrasound makes these posterior needles better suited to a separate implant process.
We don't want to get them too close to the rectum and increase the risk of rectal toxicity. And so we like to do it at a separate sitting when we can be absolutely clear where the posterior region of the prostate is. It doesn't take any longer to do, but it just improves the accuracy of the implanted seeds. So we've now inserted all the seeds into the periphery of the prostate with our stranded implants. This has taken us 15 minutes to get to this stage.